jumping straight to prescribing meds when a patient complains of issues with sleep, but this might not be the best approach for most patients. Most of us as physicians only get a couple of hours of sleep education in medical school and residency, so we don't learn how to properly work up and treat patients with sleep issues. So today I'm going to teach you my 5T method for treating patients with sleep complaints. If you're a physician, therapist, or healthcare practitioner who wants to up-level your clinical sleep medicine knowledge, go ahead and subscribe to this channel. I'm Dr. Nishi Bhopal. I'm a physician. I'm board certified in sleep medicine and psychiatry, and this channel is all about really practical tools to help you with sleep in your clinical practice. Every video is eligible for CME credits, so watch the video all the way to the end and then go ahead and grab your CME. The link to the CME is in the video description below. Also, if you want to learn a little bit more, then get my free clinical sleep mini course for outpatient doctors. It's got lots of high-yield tools that you can use today. You can get that at intrabalance.com/doctors. And lastly, stay tuned for the doors opening for my clinical sleep kit membership. It's June 2023 right now when I'm recording this. I open the doors a couple times a year, and this is a great resource with lots of other clinicians. There's lots of resources, handouts, mini trainings, live trainings, expert guests talking about how to really support your patients with sleep. It's really high yield. It's for clinical practice. It's not fluff. It's not academic information that you can't really use. So I've designed this as a resource to be the kind of resource that I actually wanted when I first started practicing. So stay tuned for that. That's the Clinical Sleep Kit membership. All right, so we're going to talk about my 5T method. I'll introduce you to that so you can have a way to think through issues with sleep when a patient comes to you complaining of fatigue or difficulty sleeping. Now, why do we need to have a method? Well, it's really helpful to have a framework, a really simple framework that you can go to in your mind to help you just kind of go through things systematically, because it's really easy, especially when it comes to sleep, because sleep is such a multifactorial process, it's easy to miss things, and this ends up in patients being misdiagnosed or underdiagnosed or being placed on inappropriate treatments or not being treated when they really should be. And so that's not really helping anyone. It's not helping our patients. And even as a clinician, it's dissatisfying when your patients aren't improving. So you can use this 5T method in your practice, try it out, and then let me know how it works for you and what you think about it. The 5 T's are to talk, test, treat, track, and tune up. It might sound really simple, and that's good because I like to keep things simple. I like things to be simple and manageable, but effective. We don't need to overcomplicate things when it comes to sleep, but we do need a system to understand what is going on because, as I said, there's so many different factors that influence sleep, and that's what makes it so interesting, but also what can make it a little bit challenging to help patients with in clinic. So the first T is to talk, and essentially what that means is to take a really good sleep history by talking to your patients, by really engaging them in a dialogue to understand what is going on, because as you may remember from medical school, from learning history taking, the patient will tell you the diagnosis if you listen closely enough and if you ask the right questions. So when you're talking to a patient, what we're really thinking through is the differential diagnosis. So you want to start by just getting their sleep history, what time they go to bed, what time they wake up, do they take naps, what is their sleep quality like, what is their subjective experience of their sleep quality, what's their sleep schedule on weekdays versus weekends, and then what are some other symptoms that they might be experiencing that they didn't think of telling you. Things like obstructive sleep apnea symptoms, restless leg syndrome, kicking or movements during the night, using the bathroom frequently during the night, if there's a mood disorder, anxiety that might be contributing, getting a sense of what their sleep situation is like, if they have a bed partner who maybe has OSA that is disrupting their sleep. So just getting a really good picture of what's going on with their sleep and what their sleep environment looks like. Why this is important is that you might have patients coming to you complaining of insomnia, and they might call it insomnia, but we can't take that at face value because insomnia is not always just that. It can be a sign of some other underlying sleep disorder. Even things like hypersomnias and narcolepsy can show up with complaints of insomnia because of the sleep disruption that sometimes goes along with those conditions. Getting a really good history and really talking to a patient about what's going on also helps to get their buy-in. So it's a way to get them motivated and also engaged in a treatment plan. Now, I know that we're busy as physicians. We don't always have time to go into these long, detailed sleep histories with patients. So that's where a intake form or a screening questionnaire can be really helpful. You can give those to a patient before the appointment and have them fill it out, and that could be a jumping off point for you for taking a more detailed history. And again, this is something that I provide in the Clinical Sleep Kit membership, some of these templates and forms. So if you're interested in that, then just stay tuned for doors opening, or you can get on my newsletter and I'll send you more information. The next T is to test. And what I mean by testing is doing different things to assess the patient's sleep. So this might include rating scales. You might be using things like the Stop-Bang questionnaire or the Epworth Sleepiness Scale or the Insomnia Severity Index, or even rating scales to assess a patient's mood like a PHQ-9 or a GAD-7. I go into detail about the pitfalls and the benefits of some of these scales in my free sleep mini course. So if you want to learn more about that, you can grab the course and get more detail. These rating scales can also be a really helpful starting point to understand a little bit more about the patient's underlying symptoms and what else might be going on with them. In the testing category, I also include doing a sleep diary. You can give the patients a self-report sleep diary to fill out. I like to use the one from the AASM. It's a free one-page grid sleep diary. It's a PDF you can download, or your patients can download it, and it gives you a really nice visual of what's going on with their sleep. You can also see if there's some circadian rhythm misalignments on there. Other tests include baseline labs. There are some blood tests that you can do with your patients just to kind of look under the hood and see what else might be going on. Some of the labs that I like to look at are a CBC, a CMP. I also like to look at vitamin levels, so vitamin D, vitamin B12, folate. If patients have symptoms of restless leg syndrome or periodic limb movement disorder, or if you have a patient who is having heavy menstrual periods, you may want to check ferritin and iron studies to make sure that there isn't something else going on with anemia or suboptimal levels of iron that can negatively impact sleep quality. And I have seen this in my practice, where optimizing their iron levels can have a really significant impact on, of course, their energy levels, but also their sleep quality. Thyroid function also falls into this category of getting some baseline labs. And again, we go into more detail about lab testing in my Clinical Sleep Kit membership, but you might want to start thinking about what labs you want to order with patients and what you might want to be looking for. And then, of course, in the testing category, we've got sleep testing. We've got sleep studies. So you can get a baseline polysomnogram or an HST. There's titration studies to make sure their CPAP or their PAP therapy is working. You can also do a study to make sure their oral appliance is working effectively for their sleep apnea. You can do sleep studies to assess for narcolepsy. There's different kinds of sleep studies. There's different indications for them. So again, you can check out my video on when to order a sleep study for more information about that. The next T is to treat. So once we've formulated a differential diagnosis, we've done some testing, now we can start to treat the underlying issue. In some cases, you might have identified that they had a sleep test and they had sleep disordered breathing. So now you're working on helping them treat that. You might have identified that they have low iron levels and they've got symptoms of restless leg syndrome. So you'll start working on optimizing their iron levels and treating any anemia. Now, an interesting note is that patients who have RLS, who don't necessarily have anemia, can still benefit from iron supplementation. So that's really interesting. The Restless Leg Syndrome Foundation has more information about that. Perhaps you might have identified that this does seem like a primary insomnia issue, and you might start implementing some CBTI techniques. You might refer them out for CBTI, which is cognitive behavioral therapy for insomnia, which is the gold standard first-line treatment for insomnia. You can start implementing a little bit of sleep restriction or compression, a little bit of circadian rhythm regulation and lifestyle management into the treatment plan. Or in the treat category, you might consider using medications short term just to get them back on track with their sleep while you continue to do some investigation and implement some other treatment measures. The key point here is that whatever treatments you're implementing should be tailored to your differential diagnosis, to what you think is going on, and that you have identified from the first 2 T's, from talking to the patient and from doing the initial testing. If this type of information is helpful for you, go ahead and click the like button. Doing so helps to feed the YouTube algorithm, and it gets this information out to more practitioners. The next T is to track. So this is where we are now tracking the effectiveness of the treatment that we have implemented. You can track using different methods. If your patient has a wearable, like an Oura Ring, which is what I have, or a Fitbit, or an Apple Watch, or some other kind of tracking device, you can use that, with the caveat that sometimes people who are struggling with sleep can get a little bit fixated on the data, and that can start to cause a little bit more anxiety. So just be mindful and look out for issues around that. That's also known as orthosomnia. So just be on the lookout for that. But otherwise, trackers can sometimes be a helpful adjunct as you're trying to get a sense of what's working for the patient. You can also continue tracking using your sleep diary. You can even use some of those rating scales that I initially mentioned to track progress. For example, if you have a patient with hypersomnia, you can use the Epworth scale to get a baseline and then use it to track their daytime levels of sleepiness. Tracking can also include the patient's self-report. They'll be able to tell you if they feel like they're sleeping better, if they have more energy, if it's easier for them to focus during the day, if they feel like their brain fog has improved, or if their bed partner has fewer complaints about sleep issues. So patient self-report is also a great way to get them thinking about their sleep issues and again, engaged and motivated to implement the treatment plan. Then the last T is to tune up. This is where you might be fine-tuning the treatment plan. So maybe you're fine-tuning their lifestyle modifications or their day-to-day habits. Maybe you're fine-tuning their sleep apnea treatment. You might be looking at their titration or compliance data. If you're not really sure how to do that, their sleep doctor can help them with that. But even just asking them about that, what does your compliance data show, or using your CPAP, just helping to get them, again, thinking and motivated about the treatments. This is where you can start to fine tune. If they're taking sleep medications, this is a good opportunity to start fine tuning their plan with that. Maybe you want to start deprescribing, or you want to start implementing a longer term plan to support them with sleep, where they can sleep without medications or external sleep aids. Or maybe you start working on relapse prevention. So maybe they have a really good system in place to help themselves with sleep. Maybe they've got some supplements that work for them and some lifestyle interventions. So this is where you can talk about, well, it's normal for people to have sleep issues from time to time, and what are we going to do if we start running into sleep issues again? So this 5T framework is a cycle. You can go around the cycle. You can talk, test, treat, track, and tune up, and go back to the beginning again as the patient is fine-tuning and refining the plan, or if they start having issues again down the line. But just use this as a method to help you think through the sleep issues and help you start to formulate your differential and implement a plan that is appropriate to that patient's situation. So what is the most common sleep disorder that you see in your clinical practice? Go ahead and let me know in the comments. If you're a physician, therapist, or healthcare practitioner who wants to up-level your clinical sleep medicine knowledge,